Okay, so the next thing we'll talk about will be the patient encounter. So essentially before you go see the patient, you want to go check the patient's charts, check their orders, check any history, anything of that nature, okay? So after we do that, when we're going to wash our hands, put on our PPE, okay? Then after that, you're going to want to introduce yourself, okay? Always introduce your name, okay, your title, the procedure you're going to perform. So for example, if I have an order for oxygen, okay, I'll go into the patient's room and say, hey, Mr. Smith, can I check your armband and look for your name and ID, excuse me, your name and date of birth, and also the MR number, the medical record number. I would just say, hey, Mr. Smith, they ordered a order for oxygen here. We just want to assess and see if you need any oxygen. My name is Chad from Respiratory Therapy, and that's what I'll be doing today. Shouldn't be nothing but a couple minutes for me, okay? Then always you want to interview the patient for any relevant history, okay? Then we get into putting the pulse ox on the patient's finger, okay, and checking our vital signs. Okay, so now that we have all the information from the patient, okay, the pertinent information, now we're going to check for our pulse, okay. Whenever you're checking for a pulse, typically you're going to use the radial pulse, okay, or you could use the brachial pulse, okay. Whenever you're checking blood pressure, you're always going to look for a brachial pulse, okay. When we're just checking for a pulse, we're just usually going to look for a radial pulse, okay? So you're just going to use your index finger and your middle finger, okay? You don't ever want to use your thumb because you actually have a pulse in your thumb, okay? And you may actually feel your own pulse rather than the patient's. Typically, like I said, the radial is the preferred location. Realistically, what you want to do is you're looking to feel if this is a normal pulse, is it bounding, meaning it's really strong, or is it a weak pulse, okay? You do have essentially a pulse oximeter, okay? You place that on the patient's finger, usually the index finger, and it'll give you the heart rate and the oxygen saturation, okay? So this would give you your pulse rate as well. The one thing in medicine, you never want to rely on machines, okay? You always want to observe the patient, okay? So I know I can get a pulse from here, but I want to verify that by actually feeling for the pulse, okay? So typically what you would do is you'd look at a clock or the watch that's on my hand, okay, and I would time out. You could do this several different ways. You could hold this for 60 seconds and you would get the true pulse, okay? Or you could hold this for 30 seconds, times it by 2, or you could do it by 15 seconds and times it by 4. Typically, 30 seconds times it by 2 is ideal, okay? That gives you an idea of how the pulse is. Is it rhythmic? Is there a beat every second or so in between? Is it bounding? Is it regular? Or is it weak? Okay. So again, you always want to make sure and feel for a pulse, even though you do have the pulse on your pulse oximeter. When checking vital signs, the primary ones you're going to check is going to be the respiratory rate, heart rate, oxygen saturation, blood pressure, and body temperature. Okay. Realistically, as respiratory therapists, the 4 most important ones to you are going to be your respiratory rate, your heart rate, your oxygen saturation, and your breath sounds. Okay, we'll talk about breath sounds in a later lab, but for the most part, like I said, respiratory rate, heart rate, and oxygen saturations are the ones you're concerned with. You will have to monitor blood pressure and you will have to monitor body temperature. These are very good things to know, but as respiratory therapists, these aren't things that we typically document. Okay, so now we're going to talk about actually how to do a manual blood pressure.
And in actuality, in your RT240 term, you will be doing rotation in the pulmonary rehab. And at the pulmonary rehabs, they require you to do manual blood pressure. So this might be the first time you do it until you hit 240. So maybe practice every once in a while.
Okay. So the first thing when you are doing manual blood pressures, like I said, I would make yourself comfortable, okay? So as you can see, I grabbed a chair. I don't know what you'll have you do in 240, but here for this demonstration, I'm going to make myself comfortable, okay? So what you typically want to do is you want to feel for a brachial pulse, okay? And I can feel his brachial pulse is right about in that location right here, okay? Okay, then from there, you'll grab your blood pressure cuff. And as you can see here, this is labeled artery. Okay, so this would be your brachial artery. I'd place that right there. Okay, wrap this around the arm. Okay, and you should have about 2 fingers placement in between here. Okay, So then from there, what you're going to want to do is make sure that your cuff is closed here, okay? Then what I'll do is I'll place my stethoscope on the brachial artery. Okay? And you can I can hear it here, okay? So typically what I'll do is I'll pump the blood pressure cuff up, as you can see over here.
Hold the bulb in the video.
I'm sorry?
Show that bulb in the video.
Oh, I didn't see it? Okay, there you go.
Okay.
There's our bulb, okay? And it has a little dial on it, clockwise and counterclockwise, okay? So if you go clockwise, it tightens it, it actually closes it. Counterclockwise actually opens it, okay? So basically what I'm doing here, the reason the stethoscope is so important, because this is where you're going to listen to your systolic and diastolic pulse, okay? So typically what I'll do is I'll make sure that this bulb is closed, the cuff is closed, and I'll pump this up to 180. .160 to 180 is usually a good enough range. And then what you want to do is slowly start releasing it. Okay. And the reason you have this, the reason you have your stethoscope on is because what you're listening for is as I pump up to about 180, you start to slowly release the balloon and you hear nothing, okay? Then all of a sudden you'll hear a beat, okay? Once that beat starts, that very first beat that you hear is actually your systolic pressure, okay? So I heard it right around about, I would say probably about 128, 130, okay? So I heard is systolic. Now the beat's going to continue as I'm slowly releasing the balloon pressure, okay? Once that beat goes away, that is essentially your diastolic pressure, and I heard that right around 80, 82, okay? So that was his systolic and his diastolic, okay? So he's probably about 128 over 82. Normal is 120 over 80. Very healthy individual, okay? So that's how you would essentially get manual blood pressure. So we're going to make sure that this cuff is closed. Again, clockwise, counterclockwise, clockwise is closed, okay? Then if it's closed, we're going to pump up the balloon. Okay, we'll pump it up to about 180, 160 to 180, okay? Then we're going to slowly release it, okay? Probably like 2 or 3 millimeters of mercury per second, okay? And you can see it pumping there. You can see it's actually pumping up and down, okay? You're probably going to start hearing the blood pressure right about here. That'll be your first actual beat right about there, okay? So as you're lowering it, you actually don't hear a beat, okay? Your first beat is your systolic, okay? So as I continue to go counterclockwise on the balloon, I lower it and lower it. Now my diastolic is going to be the last beat that I hear, okay? And then I'll just completely release it. And now we have our systolic and diastolic blood pressure, okay? So now we're going to talk about EKGs and lead placement, okay? So first what I want you to notice here, okay, is your lead 1 will go right here, okay? This will be your V1, your V2 will go right here. Your lead 3 will be around here. Your 4 will be over here. Okay, maybe lift your arm up over here, sir. Okay, and then your V5 and your V6 are going to go up around here. If you notice here, basically what you're doing is you're putting an EKG lead that's basically surrounding around the heart here, okay? So your V1 and V2 are typically going to be checking your right atrium, okay? It's going to monitor the right atrium. Your V3 and 4 are going to be your interventricular septum, and your 5 and 6 are going to be more closely monitoring your left ventricle, okay? So these would be your chest leads, okay? The remaining 4 of your 12 lead will be your limb leads, okay? So your left upper, your right upper, your left lower. Now your left lower can either go here or anywhere below your chest leads, okay? And this would be your right upper, okay? So now we will actually put the leads on the patient.
Just show the probes there real quick because they are labeled.
Okay.
Hang on, I'm going to zoom
Do you
in
want me to
on
do
it.
all of them?
No, each of them will have that marking on there. Right, lower limb. Right, is that right?
Yes. So this would be your right lower limb, and each one of these is marked. Okay.
Hang on. Okay. Yeah.
Okay. So again, left lower, right lower. Good.
Yeah, and that's a challenge you'll have sometimes to untangle these things.
Okay, so then your left arm, your right arm, so those are all your limb leads, and then these will be your chest leads. And I'm just going to put them on the order I grab them. So there's your V3, this is your V5, your V4, your V2, your V1, and our V6 right there. So now we're all hooked up with our 12 lead EKG.
Put in right now.
Okay, hold on, give it a second. Hold still for me, sir. Oh, there we go. Nice. Stay right there, LT. Oh, just like that. Oh, got a little. So this will be your EKG anyhow. I was trying to get a better rhythm here. Hopefully it'll show up a little bit better on the print. Okay, so here's our EKG rhythm right here. Okay. Most importantly to note is lead 2, which you can see on the bottom there. It runs all the way along the bottom of the paper. That's usually where you're typically going to read your EKG rhythm. Okay. We'll talk about all the other leads, the chest leads and the limb leads in lecture. Okay, so now when you're removing these leads from the patient, you want to be careful because this is sticky. You may have patients with hairy chests. Okay, you want to definitely be aware of that. Okay, so usually what I'll just tell the patient is, hey, I'm going to remove these leads from you. Okay, so first thing I'll do is I'll take all of this off right here. Okay, and these ones are nice, they just clip on. Okay, that's how most of them are in the hospitals anyhow. Okay, so now the part where we have to take the stickers off the patient. Okay, so typically what I'll do is say, sir, I'm going to be pulling these stickers off, and I'll rip them off as quick as possible. Usually I just hold them to the back of my glove. Okay. Okay, and then we're done. One other thing I need to mention though, is if you have a female, okay, you need to be able to be discreet when you're dealing with females, especially as a male, okay? Typically, you do not need to disrobe a woman or a patient in general, okay? This gentleman here had a shirt on, so it was easier just to take his shirt off, but typically if you have a hospital gown on, you would just pull the hospital gown up to the breast line, and you could pull the neckline of the patient's gown down to their neckline, okay? You could put your leads 1 and 2 right here, and then you can just follow along right here, okay? If you ever do have a woman who has a lot of adipose tissue in this area, you would just use the back of your hand, let them know, ma'am, I'm gonna have to lift your breast up to adhere some stickers for this EKG, okay? If you feel uncomfortable, always ask someone to come in with you. You could ask another respiratory therapist, preferably maybe even have a female respiratory therapist and come in and do the EKG for you in exchange for, to help her out with something she may need later. That is another option. Okay, but you always want to make sure you be professional and discreet whenever you're dealing with patients, because remember, when you're in the hospital, patients are already kind of compromised. They've kind of sacrificed their dignity in some situations. So you definitely want to be aware of that. Okay, always be professional and be discreet with everything. Okay.